Hello, 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 my digital pathology trailblazers. It is around lunchtime in Pennsylvania, USA. It's 12:15 exactly. And today we're going to be talking about the pathology workflow. Before we dive into the topic, please let me know in the comments. I want to see that you're there. Please let me know in the comments, where are you tuning from? Let's see if I can even see your comments. And we are live at the moment on LinkedIn, YouTube, and Facebook. So please let me know where you are from. I'm waiting for some comments so that I can see where you guys are connecting from before we dive into our topic. Waiting for some comments. Yes, so I see people from the US. I see people from the UK. Hello. I see people from France, Dublin. Fantastic. Comments are working. We'll see. Everything seems to be working. USA, welcome. Daria from Dublin, welcome. And I see many Polish names as well. Fantastic. Philly, UK, Newark, perfect. Fantastic. So thank you for joining me live. Before we also start about the pathology workflow, I want to know where you're at regarding the knowledge about this, because we're going to be starting from the basics, going a little bit into deeper. But my question for you is, have you ever been in a pathology lab? Give me a yes or a no in the chat if you have actually in person visited a pathology lab. It could have been a human pathology lab, veterinary pathology lab. And I see people coming in from India. And we have KV from Path Presenter. Welcome, KV. I see some familiar names here. I see Robert. Hi, Robert. Great to have you here. Fantastic. I'm so happy to see many of my digital pathology trailblazers joining me here. So I see some people have been in the pathology lab. Yes, Rena was at the pathology lab. Many yeses. Okay, yeses and thumbs up. Whenever you guys, if you find this thumbs up emoji, give me a thumbs up, because this is gonna help the algorithm boost our live stream and push it to more people, so that more people can learn about pathology workflow today. And I also see some people who have not been in a pathology lab, which is perfect, because we're going to be talking at the beginning of the broadcast. We're going to be talking about what actually happens in with the here my skin, with my tissue, to the moment where a pathologist or a researcher looks at it on a slide. And then we're going to be talking about two different workflows on the analysis, on the slide interpretation. And one is the classical diagnostic workflow, that is when a sample of our body is being sent for analysis, and often it's in the oncology context when there is a suspicion of a neoplasia, but also dermatopathology, different specialties of pathology follow this classical, I will call it classical diagnostic workflow, both human pathology and veterinary pathology. And there's the research workflow, and there can be many different shades and sides of the research workflow. I'm going to focus on the one that I'm most familiar with. It's going to be the toxicologic pathology workflow, and toxicologic pathology that supports drug development. And before we start with the tissue, let me know which part is more familiar to you. Put a D for diagnostic and put R in the chat for research. I have always been on the research side. So I am currently working to support drug development. And there's a question. And also, by the way, put questions in the chat. There's no presentation. There is no slides. It's going to be me talking you step by step through the process and explaining concepts. So if anything is unclear, let me know in the chat, because I can show your comments, like what Doug asked, and we can address them. I will be taking them later, those questions from the chat, and at the end of the broadcast, we're going to be answering everything that you had to ask me. So this is fantastic. And I see we have more or less equal amount of research and diagnostic. I have some D's, I have some R's. Good. I'm going to try to cover it. So let's dive into it. Let's start with the tissue. What's happening to the tissue? So the tissue is being taken at a place. Usually it's your physician or wherever you go to the doctor and then decide to take a sample, or it can be a veterinary practice. I'm a veterinary pathologist myself, so this is the thing I studied. I visited the human pathology laboratories, and I'm familiar with that as well. But when I did my training, that was in a veterinary environment. So the tissue is being taken at the first point of care. And first thing that happens with the tissue is it's getting put in formalin. Formalin is a fixative. Fixative means that it kind of fixates, makes this tissue immobile. And I will mute myself because I have to cough. Give me 1 second. I'm sorry. We're live and these things happen. I think I'm good. I'm going to continue till the next cough attack. I'm having a cold, but I decided to be with you anyway and talk you through this situation. I apologize if I have to mute myself again for coughing. Hope it's going to not happen too much. Okay, so fixation. The goal of this is to, another quick, oh my goodness. Okay, the goal of this is to keep everything in the tissue as is at the moment of, and now I'm crying. That's very sad. Just joking. Anyway, keep everything in the tissue as is, to make it immobile, to make the dependencies between the structures in the tissue the same as they are at the moment of when the physician, the doctor, is asking the questions, what can be there? Because if we don't fixate it, if we leave it and it's not fixated immediately after taking, there are changes happening. Those cells are dying, and we don't want this to happen. We want this to be as it was in the living organism, as it was in the living patient. So that's the first thing that's happening. Usually this is happening, so if it's in the lab, in the pathology lab, it already then enters the tissue processing workflow and all the other steps. Sometimes it's being sent to the pathology lab. So then it has to be unpacked, documented, and the first step that actually is already a part of the pathology evaluation is the gross evaluation. And gross evaluation is when you look at the tissue with your eyes and you measure it with whatever you can measure. So like the most primitive and the classical, and actually still in many places used way to measure it is just a ruler. You take a ruler, you measure it in all dimensions, and you describe it. You describe the color, shape, all the information that are relevant, and there's usually a checklist for what you have to measure, and this then goes for further evaluation. So we describe the tissue, and then the next thing that happens is we cut it. So the end goal is, before putting that tissue on the slide, is before viewing the tissue under the microscope. Basically what we're viewing is a very, very thin slice of tissue. So the steps to get it to this very thin slice is we first cut the plane where we actually want this tissue to be visible, the thing where the lesion is, where the change is. And just to confirm with you guys, are you still hearing me clear and seeing me well after me muting and unmuting after the coughing attack? Give me a sign, give me a yes if everything is okay in the chat before we move on. That would be great. And as I ask you to do that, of course, I have to cough. So bear with me. And I hope I see, okay, I see that you can still hear me and see me. This is great. So picture is not moving. My picture is not moving. That is not good. I'm going to wave at you and tell me if you see me waving. Okay, I see some yeses. Okay, good. Then, well, I hope you can still see me and not only hear me, but hearing is more important than seeing. So good. So we have this structure that we're cutting, and let's say this is my ring is the thing of interest. So obviously we want to cut where the thing of interest is at those places that are of interest. And the thing is that we don't have to like just choose one. Okay, fantastic. I get other messages that I'm waving. Perfect. You can see me. So the interesting thing is obviously we are moving from 3D super information rich piece of tissue to a flat image, like a super thin flat image. So we are reducing the dimension. But what we can do, we can cut this tissue at multiple planes wherever we think this is relevant for the later diagnosis or evaluation. And there is a lot of expertise going into how to cut it. So this is extremely valuable because the places where we cut this tissue then later determine what information does the pathologist, does the researcher get to later analyze this tissue. Okay, so we have it cut, usually thin slices, and then it's being processed. So the tissue has to be processed different. I'm not going to go into detail with this, but basically there is processing, there is dehydrating, putting alcohol in, taking it out. But basically the end goal is to have all the structures as they were in a 2D plane on a microscope slide. So that is what's happening. And when we have this processed, the other thing is we have to make it so tissue is like soft, right? The fixation makes it a little bit harder, but doesn't really make it hard enough to cut a very thin slice that you can later put on a slide. So what do we do? What's usually happening to make it sliceable? To make it sliceable, we embed it in paraffin. So those pieces of tissue are in cassettes, and then around them you are pouring paraffin. Paraffin later, you're pouring liquid paraffin that later solidifies and can be cut, can be sliced as cheese. And that gives us this 2D thing that we want to put on our slide. And then I see people waving at me and saying hi. Hi, Lynn. Great to see you. I am so happy that you, my digital pathology trailblazers, are here. And I need to use the tissue again, but no coughing now. I'm just taking care of runny nose. So, by the way, speaking of runny noses, I have had this cold since last Sunday. And at some point, I decided I'm going to stain what's in my nose. And there is a video on Instagram, what exactly is in my nose? And you can make a guess. While I'm walking you through the next steps, what kind of cells do you think are in a nose of a person with a cold, like myself right now? Just a little fun thing. And later I can send you all a link to this little video. But where are we? We are at the stage where we have our flat, sliced as cheese piece of tissue together with paraffin. Then, this is already on the slide, and like we don't want to, there are a couple of things that have to happen before we have the most classical is H&E, hematoxylin and eosin type of staining, which we're gonna get. But okay, let me be structured. Let me be super structured. We have the slice of our tissue cheese, so to say. On the slide, we have to get rid of this paraffin because we only want this tissue. So there is also processing and taking this out with different chemicals from the slide itself. And another thing that has to happen, because this is not colored, there is no contrast in this. This is like the native colors that a tissue has, which after processing are basically like grayish, not really anything colorful, not too much contrast. So to add contrast to this, we need to stain it. And I already mentioned the ubiquitous diagnostic stain, hematoxylin and eosin, the pink and the blue images that are being used for diagnosing, for evaluation. There's plenty of other staining techniques, but this one is the most common, lowest effort, most information yielding technique that every pathologist and every tissue scientist is familiar with. So before I move into the next part, the workflow, the different workflows, let me know in the chat, have you seen the grossing? Put a G for those who have been in a pathology lab. Have you seen this part, this pre-microscope part? Put a G in the chat if you have been, if you have seen it, either in a human pathology lab or in a veterinary pathology lab. Waiting for some comments, to see if anybody has seen this part of the pathology workflow. So we kind of, with this part, we wrapped the pre-evaluation part of the workflow. What's happening with the physical piece of tissue that is later being evaluated. And today we're going to be talking only about those workflows. We're not going to be talking about digital pathology per se. Digital pathology, most commonly, there are different aspects of digital pathology, but happens after the staining already when we scan. And I see our comments. I see a couple of people who have seen the grossing, a couple of people that have not seen the grossing. Okay, so those who have not seen the grossing, was this description valuable for you? Give me a like, give me a thumbs up or a yes in the chat if this was good explanation, and if not, put the question. And I have a question here. I'm going to show it. Can the same tissue slice be stained with different stains? Yes, it can be. You can destain. This is not the usual workflow that's happening at scale, but in a research setting, this is something very desirable, especially if you want to correlate the different things that you see from different stains. You want them to be visible on the exact same piece of tissue. So yes, the tissue can be stained with different stains. Okay. So yeah, put the questions in, every time I finish a part of what I want to talk to you, I'm going to be pulling some out so that we can answer them during the live stream. So moving on to, so we already stained our tissue. It has color, it has contrast, it's ready to be evaluated. And it can be evaluated in the diagnostic setup, where the question is, okay, what disease is happening there? What changes are happening there? And this diagnostic question is also persisting in the research setting, but the main difference is here we are working on samples, on tissues from one patient. we can have many samples from the same patient if the change was big, if there were multiple changes on the patients, and we have them all in our, usually they're put on a slide tray, and the pathologist takes the slides and puts them under the microscope and evaluates them. So there can be a whole slide tray or multiple trays from the same patient, but the like evaluation entity, let's call it like that, is the patient. Whereas in a research setting, usually you are investigating a phenomenon on groups, on not really, so the groups obviously consist of individuals, but the effect, the changes that you're evaluating is between groups. Usually it's a group that didn't get anything and a group that got something, and you're checking, okay, are there differences between those groups? So the fact that one single patient or one single experiment subject from one group has something doesn't necessarily need to mean a lot, because you later take your whole group and compare the groups. So I see that I am frozen. Am I still frozen on let me know in the chat if I'm still frozen. That is so sad that I'm frozen. And I see some comments that I'm frozen. Well, then it's going to be a frozen broadcast with me speaking to a frozen image of myself. Anyway, that's what it's going to be. So what is happening then? So diagnostic workflow, patient, and then research workflow, groups of patients, of animals, of maybe tissue samples. Okay, I see I'm not frozen anymore. That is fantastic. Okay, so the thing is that some of you might be viewing it live, and those who are viewing it live, put an L in the chat there so that I know how many of you are live, and some are watching a replay. So put an R if you're watching a replay, if it's already past the time that was allocated originally for this event, and put an R in the chat if it's live, if you're here with me right now live. And so, yeah, I wanted it to be structured, and I'm like all over the place. But diagnostic workflow, we said patient, and research workflow, groups. This is later has like downstream effects on the products in the industry, and I have seen many of my digital pathology trailblazers from the industry sites that are offering products, and I see people viewing live, great, products for pathologists. And often there is a confusion, well, it's a pathologist, they like diagnose. Yes, but they all diagnose, they all evaluate tissue. But if somebody is evaluating a patient and all the samples that they're evaluating belong to this one patient, they're going to manage their workflow differently than those who are doing a research workflow, where they want to like compare groups. They want to compare, let's say, the same organ. And in a few minutes, I'm going to tell you exactly like how it looks in Toxicologic pathology. But generally, there are differences in workflow. Even though we all do the same thing, we evaluate tissue, the conclusions, we later interpret the conclusions in a different way. So diagnostic pathologists, they have a patient, they are making decision about the single patient, because then the treatment of the single patient depends on the diagnosis. Whereas the researchers are evaluating groups, and what depends on the decision that they're making is, let's say, are they going to be proceeding with the same compound later that they were just investigating? Where are they going to go with this dose or that dose of a chemical that they're testing on different tissues, right? So for the researcher, it's very important, for example, to compare different things, to compare within the same experiment. Whereas diagnostic pathologists, they might want to compare something as well, but they usually compare the patient that they're evaluating right now with previous patients that they had. So there are important differences in workflow. Let me know if this makes sense. Give a thumb up or write a yes if this is logical enough for you. If not, put a question in the chat which aspect is not clear, and I'm going to dive into this as well, so that you leave with a clear understanding what the different paths are. So while I'm waiting for your comments, and I'm going to be bringing them in, let's dive into the research workflow, research pathology workflow, and specifically toxicologic pathology workflow. So this is even toxicologic pathologist supports the development of drugs, but they support the development of drugs at a certain stage of this development process. The development process, drug development process, is a, we say in Poland, subject river, like super broad, and that's for another broadcast, for another occasion that we're going to be talking. But this place where a toxicological pathologist is supporting this drug development is where there's already a candidate drug, a substance that has a potential to become a good therapeutic, and we are checking if this substance is safe on living organisms, on animals. This is where a toxicological pathologist comes in. And what's happening there, and I need to cough, so bear with me. Coughing and runny nose. Fantastic addition to this broadcast. Anyway, doesn't matter. We move on. So we're checking if the substance that is a candidate for a drug is safe. Why do we need to check if it's safe? Because later, at the later stage of drug development, those substances are going to be tested on human patients. So we are checking on animal patients if they are safe to be moved farther along the drug development pipeline. And what is happening in this setting is there is a compound, and we check different aspects of this compound, different ways of giving it, and different doses. And I'm going to focus now on the different doses. Before I tell you exactly like what's the most classical way of a toxicologic pathologist of evaluating slides, let me know if you were even aware of those veterinary pathologists being involved in drug development, who is familiar with toxicologic pathologists or knows another one than me. Put a T in the chat. Give me a T if you were familiar. Give me a no T or an NT if you didn't know that veterinary pathologists were involved in this part of drug development. So I'm going to be watching for your comments, and we'll continue. So common thing to evaluate is which dose of this compound is the right dose to give. And usually the most classical study design for a toxicologic pathologist is a comparison of 4 groups. The first group doesn't get any of the compound, but undergoes all the same procedures that all the other groups go. And then we have group 2, 3, and 4, and those groups get higher doses. So group 4 is our always high dose, and here are mid dose and low dose and mid dose. The key to this setting is, and I often get this, and I see people who are totally new to this subject, and I see also people who have seen and know some toxicologic pathologists. Fantastic. So we have people from both sides. Going back to the groups. 4 groups, different doses. And I often get this question, like, don't you do it blinded? Like, you know exactly what each animal gets? Yes, I know exactly how much of the compound, what the dose is for each animals. Not only that, because we here want to evaluate this as the only variable, this as the only thing that changes in our experiment. A million things can change, like food can be different, temperature can be different, stress level can be different. We want to keep all these things constant, so all the animals from our experiments are being held under the same condition. The only variable is that some of them get the medicine. And then we check the tissues for changes in the tissues. And from the workflow perspective, we have our control group where we should not see any changes, and we have our high dose where logically we should see the biggest, the highest severity, the worst changes. And then we have those two groups in between, and we check, okay, which group got the dose that would be safe? Which group got the dose that could be carried on and be given to humans? And this is kind of a simplified workflow because in the drug development process, it's not just one study with 4 groups. It's a series of different studies that evaluate different aspects. And this is a regulated environment. This is dictated by FDA, Food and Drug Administration, and by the Code of Federal Regulations in the USA. So every pharmaceutical company knows what requirements, what studies they have to conduct to be able to take their drug candidate to the next level. And just before we wrap up, I'm going to tell you that from all the drug candidates, if we had 1,000 candidates, then we would have only maybe 100 candidates that undergo the tox safety evaluation. Then we have maybe 10 candidates that go into human clinical trial, and then only one makes it to the pharmacies and is being approved. So this is where the research pathologist works. And that is it. Tell me if this was valuable for you. I know that some of you I've seen who is joining me here. You are super experienced in this. So let me know if you learned a lot or a little bit. I want to know if you learned a lot from this or a little bit. And I am so happy that you were here with me. I'm going to look for some questions. If we have any more questions, and put me some questions in the chat if you have any more. I guess we are out of questions. If you come up with questions after this has been broadcasted already, go ahead and put them in the comments, because the comments can still come in, the likes can still come in, and this can be pushed to a broader audience. To if you see somebody, you know somebody who would be interested in this information. Why I even decided to cover this topic that seemed to be like kind of basic, maybe in people who are interested in pathology, especially in digital pathology, because I have seen gaps. And I have seen from you also that not everyone has been in a pathology lab. So I thought it's going to be valuable. Let me know if it was valuable, and see you next time. I hope I was not frozen for this waving. Take care, everyone. Thank you.